doctor says something like, I'm afraid the news is not good. There is no other treatment for us to try. I'm sorry. It may close the door to possibilities of a cure, but it does not end the need for medical support. Nor does it end the involvement of family and friends. So our goal today is to describe the support and medical care given during the times surrounding death, to understand what the terms hospice and palliative care means, and knowing available options.
Again, I am Dr. Teresa Catron. I am currently the medical director of Blount's Hospice and Palliative Care Program. And one thing I really appreciate that you said, Teresa, is that when we are faced with end of life, that doesn't mean that medical care ends. It just means it refocuses onto the type of care that's being provided. So I'd like to really emphasize that hospice and palliative care are actually medical subspecialties, just like cardiology, gastroenterology, or pulmonology, and that folks who are working within that field actually have very specialized training in symptom management and support for people who are dealing with chronic illness and end of life. So it really is ongoing medical support to ensure that all of your medical, emotional, and physical needs are met when you're dealing with these chronic issues. So the first question that we often get, of course, is what's the difference between hospice and palliative care? And it's a bit of a semantic issue, but there is a regulatory foundation for it. So palliative care and hospice both deal with chronic life-limiting illnesses throughout that continuum of progression of disease, but also at end of life. You can be at end of life and only be receiving palliative care without hospice. Or you can be receiving hospice at end of life, but never have had palliative care in the past. It really, though, is preferable if you can have this level of support from the first time that you've been given information about a chronic life-limiting illness, and then have palliative care support until that time when you qualify for hospice. Hospice is specifically different from palliative care in that it's a regulatory benefit out of CMS. It's a part of your Medicare benefit, and it's also a benefit under other primary insurers. You have to meet very specific criteria to receive that benefit. And that criteria effectively is that you have a life expectancy of 6 months or less. Now that doesn't necessarily mean that you have to pass within that length of time. We do have many patients who survive beyond that initial 6 months, but they still qualify for the ongoing hospice benefit to provide support at end of life. Okay? So the key difference there is that hospice becomes an insurance benefit, whereas palliative care is really more of a consultative benefit. Okay? So that's the semantic part of it. In terms of what we do, absolutely very similar. Symptom management for symptoms that are associated with chronic disease or end of life. And an example, a chronic medical illness that can lead to death is COPD. Does everybody here understand what COPD stands for? Chronic obstructive pulmonary disease. That disease has a very long course. You can be diagnosed with it, say, in your 40s, depending on how many cigarettes you smoked your whole life. But you may have a rapid progression of disease with COPD, or you may have a very prolonged progression of disease. But somewhere in that progression, you're going to develop a period of time where you're having frequent illnesses that are related to what we call exacerbation of COPD. And if you've got that disease and have been hospitalized and your doctor has said, oh, you're having exacerbation of COPD, that basically means that your disease has reached an uncontrolled state that requires acute intervention, and we provide that in the hospital. But as your disease progresses and approaches a period of time where it indicates end of life, you're going to see that happening more and more frequently and become less responsive to medication. And that is ultimately when a physician might come to you and say, you know, you're not responding to medicine. We can't seem to keep your symptoms under control. I truly can't do anything else for you. I think you need to consider hospice. And that's when we would come in and provide you with a different form of medical management for your illness. We might continue all of your medicines, but we have to recognize that they're very limited at end of life and what they can do to manage symptoms. But we can use many other forms of medication to help control the symptoms that are associated with your disease. The sensation of shortness of breath, the sensation of anxiety. Any of us, I have asthma, who have had trouble breathing know how anxious that makes you feel if you can't catch your breath, you know? So all of these associated symptoms fall under the realm of hospice and palliative care. And that's where we begin to focus medical care, as opposed to a curative process. When should you talk to a doctor about either of these two things? At any point when a physician tells you that you have a diagnosis that is progressive and does not have a cure, that is the point. Because sometimes medical care requires a lot of planning. Well, not even sometimes, I should say. Always. Prolonged medical care requires a lot of planning. When your doctor comes in and tells you, for example, well, your chest x-ray and our pulmonary function tests tell me now that you do have COPD, and depending on how well you respond to treatment, we have a life expectancy of 30 years, okay? Should you wait 30 years to start planning for that future? Absolutely not. You don't necessarily have to get down into the nitty-gritty of things, but at a minimum, you should begin talking with your family, with your doctor, about at what point do you think I will be at the end of life. For your doctor. For your family, you should start talking about what your wishes would be when your disease has progressed to the point that we can no longer provide curative care, okay? So those discussions should always start very early after a diagnosis has been given. You know, oftentimes people will say, well, what kind of diagnosis is that? You know, is that COPD? Is that the only one? Well, I think the easy answer is no, there are tons, you know, and most often people will equate hospice with cancer, okay? You get the big cancer diagnosis, it's incredibly frightening because we really do not have many cures for cancer. And depending upon what type of cancer you've been diagnosed with, that can indicate a short life expectancy or sometimes slightly longer. We just don't know sometimes. But obviously, that's a point where you have to begin planning as quickly as you can with your family and with your doctors. But the things that are a little bit grayer are the hardest ones to know. Heart disease. Heart disease is the #1 killer in our country. So at some point, if your doctor comes in and says, you've got plaques all over the place, your heart function is starting to go down, that usually is going to indicate this is a time to start planning ahead. Obviously, you might want to make lifestyle changes or medication changes that will help to prolong your life. But at some point, you do have to sit down and share with your family what your personal goals would be at end of life. And that includes discussions about advanced directives. Would you want a feeding tube? Would you want CPR? Would you want to be on a ventilator? All of these interventions that can come with chronic disease. One of the most difficult diagnoses to receive, that is a qualifying diagnosis for hospice, is dementia, Alzheimer's disease, frontotemporal dementia. There are many forms of dementia we know now, and we do see folks that come in to hospice in the advanced stages of their dementia. The unfortunate thing with dementia, obviously, is that it is, again, a very prolonged chronic illness. We know that it's often finally diagnosed late, and we can expect a life expectancy after a late diagnosis of anywhere from, say, 3 to 10 years, depending upon where in that progress you are when you're diagnosed. The difficult part is knowing, when does this mean that we need palliative care or hospice? And I might suggest, again, very soon after that diagnosis, if only to learn about the support that's available to you and to have someone who can help to guide you through the progression of that disease or any other chronic life-limiting illness. How many doctors does it take to approve of hospice care? So, really only one. I mean, one doctor can tell you that there are no additional treatment options for you and that it's time for hospice. And that physician can then refer you to hospice. However, again, we get into a regulatory issue, and the regulations under CMS state that 2 physicians must certify a patient for hospice care. Now, if a second certifying physician is not available, and that could be an example of someone who, say, does not have a primary care physician and they've been told in the hospital, maybe that this is it. We found this cancer extremely late, you maybe only have a week or 2. And then in that case, the hospice physician can provide both of those certifications, okay? So there's a lot of nuance to the regulation, but truly, the most common thing that happens is you have a primary or a subspecialist who is managing your care, and they will be the ones to put that initial referral in place, and then the hospice physician will provide that second certification so that you can receive the benefit. There's a lot of paperwork that goes with enacting a hospice benefit. That's another big difference with palliative care. Palliative care doesn't need a lot of paperwork. We just come in as a subspecialist and consultant and can help to support you through chronic illness in managing symptoms and educating about what to expect. But when you elect that hospice benefit, unfortunately, like most insurance processes, there's a lot of paperwork, and you kind of have to sit down and do it. And even on our end, there's a lot of paperwork. So, but we get it done, and hopefully our patients are getting everything that they need.
Okay, so I'll just touch a little bit on that palliative versus hospice, because I am a palliative nurse practitioner. I work in the hospital. I also see patients in their homes. I go to facilities to see loved ones, so that can occur anywhere. But my biggest role in a palliative is education. That is 100% what I'm there to do, to help patients and their loved ones navigate through a very tough time, through a very tough diagnosis. You know, mom's diagnosed with Alzheimer's. I don't know what to do. I don't know how to get her resources. That's what I'm there to do. I'm there to help. So I do help with some symptom management. I do a lot of guiding. I do a lot of education, a lot of support. And then when we transition, when it's appropriate, when you feel like your loved one is ready for hospice, that's when we get a lot more resources. I'll let Stacy talk on that. But what is it like to receive hospice? And so hospice services are very specific in, as Dr. Catron touched, they're end-of-life care. The first and foremost, you're going to get a nurse that comes out. It's going to be a very lengthy stay, usually 2 to 3 hours, and she's going to go over hospice benefit in detail. She, like Dr. Catron pointed out, is going to have you sign a lot of papers. She's going to talk about our on-call process, which is very important. She's going to go through your medication list from start to finish. She's gonna go through wound care if that's appropriate. Doctor says, you know, we need to do XYZ to these wounds. And they are gonna talk about how often they'll be visiting. That's the number one question I get. How often will your nurses be out? My stock answer is it's patient specific, because every patient is an individual. They have individual needs. Some of my patients that are a little more stable, and I think about the newly diagnosed cancer that doesn't want any treatment, they just want to live the best quality of life, and we bring in hospice, they're usually a little more stable. That patient may be seen once a week. And then as we get closer to more imminent passing, we get daily visits. And I tell everybody, most everybody else is in between, 2 to 3 days a week. But if you need us every day, we're out every day. If you don't, we're not. It's patient specific. You also get some bath aids that are available with a hospice benefit. So a lot of times, families are still working, they're still doing a number of things. The nurses and the bath aides, we get a chaplain, we have a phenomenal social worker, and I'll let Stacy introduce herself in a minute, but those are all services that are provided to help you through this really tough time. The equipment, I'll go back to the medicine in a minute, the equipment is provided by your hospice benefit. So if mom needs a bed, if dad needs a walker, those are all things that we can get in. It doesn't have to be started immediately. It can be started, let's say dad is still sleeping in his recliner because he's got COPD and he can't lay back. We keep him in the recliner as long as it's feasible, and then eventually transition him to a bed with a possible bedside table, bedside potty. All of those equipment needs are facilitated through your hospice benefit. Oxygen is the other question I get. With hospice, we're very comfort focused, right? So we're not doing extensive medical treatment. So we will give oxygen for comfort, but sometimes we don't give the BiPAP is one of the questions I get, or a non-invasive ventilator at home. Those are typical things that we don't do because we're focusing on their comfort and end of life. We will use medications to help support the air hunger that some of my COPD or heart failure patients have. But I'm not going with those big machines and kind of those heroic things. I will go back to medications. This is the number 3 question I usually get, is when do we stop the meds? Do you just, unfortunately there are those rumors out there that hospice comes in, they pull off your medications, they give you a big shot of morphine, and you pass. And that is not facts. Not to say that doesn't happen, but those are a specific circumstance. On average, when we take you on as a patient, that nurse goes over start to finish every medication that you have in your cabinet, including Tylenol, ibuprofen, vitamin D. She goes through the whole list. We then talk to you as a loved one or the patient and say, what is your goal? Some of my patients say, I want to reduce as much as I can. Okay, the first thing I'm going to take away is your vitamins. Let's keep the important stuff. Let's keep those heart drugs, the blood pressure drugs. Let's we'll reduce the vitamins first. Then some of mine say, I don't want to take anything. I'm ready to just be done. So they opt to stop some of their heart meds. They opt to stop some of their blood pressure meds. We're okay with that. Again, I'm there to assist with your comfort. So I let patients and their families kind of guide that. I usually tell them there's 3 times. Number 1, if the medication is not working, I usually will stop it. If it's causing harm, I will usually stop it. And unfortunately, a lot of patients at end of life get to a point they can no longer swallow a tablet. and I have no choice but to stop those. And so we're very open to discussing with patients and their families about what their goal is, and let's do this together. What if they want to take them till they can no longer take them, that's okay. I use heart failure as an example. There are a couple of heart failure medications that are truly a last-ditch effort, Entresto being one of those. We sometimes will stop the Entresto. I will give you a comparable mix of medications, but it's not the same. We're going to manage those symptoms the best we can, but once you're on a hospice pathway, usually our goals are comfort. The next question, isn't hospice for people with just a few days left? I will scream to the top of the mountain, no, because those patients have usually went through a lot of suffering, and they lose the benefit of hospice if they're waiting till their last days. I encourage anybody that has questions about it to talk to your doctor, to have that palliative consult. Let us come talk to you. But with hospice, I am not, I'll give you for example. I talked with my father recently, who does have a number of issues. His questions were, will you not let me go anywhere? You'll just keep me at home, you'll put me in a bed, you won't let me, go hunting, you won't let me go fishing, and I've explained that is not what hospice does. We want you to focus on quality of life. We bring the care to you. We recognize you have an end-stage disease process that is going to shorten your lifespan. We don't know what that is, but I want you to not spend every day going to the doctor's office. And that's what he's currently doing. He spends more days a week going to the doctor than he does living at home. And some of my patients are in the hospital once to twice a month. Is that a quality of life? Now, at the end of the day, only you can decide that. But if you do not feel that is a quality of life, running back and forth to the doctor all the time and in and out of the hospital all the time, that's where hospice can come in. We will manage your care. I will manage your COPD. I will manage your heart failure. I will manage your dementia symptoms and try to give you a quality of life. So please don't wait till the last few weeks. You miss out on a great benefit if you opt to do that. I touched a little bit about the staffing. Again, you have hospice nurses. They will come in. Their visits are usually, on average, about an hour. They're not in home 24 hours, but they're certainly available by phone 24 hours a day. We have an on-call hospice nurse. If you wake up at 2 in the morning and you or the patient is saying, I'm short of breath, or I'm in pain and I've taken my medicine and it's not working, it's not enough, you're going to call that hospice nurse. They're going to get in touch with one of the providers, and we're going to get you a little more medicine to help ease that off. Same thing with falls. We recently, unfortunately things happen. Patients fall in the middle of the night. You're going to call that hospice nurse and say, Dad just fell. He's in the floor. He's hurting real bad. We're going to help you direct that care. They may actually have to come out and do some wound care. So we are available by phone 24 hours a day. The bath aids are usually about twice a week. Some of my patients never utilize that, and some of my patients absolutely love to see those girls coming. They are phenomenal, and I've seen them braid hair, paint toenails, so it's more care than just, let's roll mom, get her a bath, and get out of here. They're phenomenal. Cannot speak highly enough about those ladies. Jeremy is our chaplain. This is another question I get a lot. For me, he does more than spiritual care. He will come in. A lot of patients or their families that come to us are really struggling with their bereavement. They don't know how to process what's going on. And sometimes Jeremy just listens. He's a great listener. He may sing a hymn. He's pretty good at that too. But if you're really struggling with that bereavement process of the impending loss, he is great. Stacy will also do this. She's pretty good to help you with that. She will talk a little bit about her services, but our social worker, again, she's phenomenal. Stacy, we could not do what we do without her. And then with that, I'm going to turn it over to Stacy.
Hey everybody, I'm Stacy Hillenbrand and I'm the social worker with Blount Memorial. So I go see every single person that comes onto our care. It is part of your Medicare benefit. I'm a requirement, that's what I tell people, because sometimes people are like, why in the world is a social worker coming to my house? Because people sometimes get a little weird about a social worker. They think things that are very incorrect. So my whole role is, I just say I'm a helper. My whole role is to come into your home and see how I can make your life easier on this journey. It's a hard decision to make, and so I want to support you in whatever, we want to support you in whatever ways that we can, and that comes in a lot of ways. I mean, I'm an advocate. I help people plan for their future. One thing that I do want to bring up that I feel is a very common misconception when people come onto our care, and it's unfortunate. People sometimes believe that when they come on to hospice that we're going to just be there all the time, helping them provide care to their loved ones. And that is unfortunately not true. That is not what hospice provides, and that is always a very difficult conversation. I'm sure, I know there are caregivers in this room today, and it is a very difficult task. It's very difficult to be a caregiver. It's draining in all the ways. So a lot, honestly, of what I do is help people figure out ways to manage that caregiver stress that comes with providing care to your loved ones 24/7. And so a lot of my conversations are based around cost of care and available resources in our community. And I have to just say it before I forget, because I don't want to forget, I love the Office on Aging. They deserve a bunch of awards. I tell people that. I don't know how I would do my job without them. If you don't know all the resources they have available, you need to talk to them. They're amazing. So I just want to tell everybody, if you don't already know this, long-term care, things like hiring an agency, a caregiving agency to come into your home, or going to live in an assisted living facility or a nursing facility, that is not covered by Medicare. Most of you probably know that, but some of you might not. It's not, Humana's not going to cover that, in none of your supplementals, nothing. That is a private pay industry, and it's important for you to know that if you're planning for the future. So often that's what my conversations center around with people is, are you able to privately pay for the care that you might need in the home or outside of the home? And then if it's not, there are other resources that are available to you, like getting on a program called Choices Medicaid, and the Office on Aging helps me with that. So that part is complicated as far as planning for the future for care. But if you're a veteran, just know, like I need you to know, that if you are a veteran, there are so many resources available to you. If your loved one is a veteran that you're caring for, please, 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 if they're not VA healthcare enrolled, get VA healthcare enrolled. There's a lot of pushback sometimes with veterans about being VA healthcare enrolled, but I need you to know, you will reap a ton of benefits if you involve yourself with the VA healthcare. Mm-hmm. If you have questions about that, I'm also happy to assist. Aid and attendance for spouses of veterans. I mean, so there are a lot of resources available to you if you're a veteran or a spouse of a veteran. Don't want anybody to miss out on what they're entitled to for serving our country. One of the questions here is kind of answered earlier. Yes, hospice is available in assisted living, memory care, nursing facilities. We will go anywhere to see you. And then, how do you get information about hospice? Really, and y'all can chime in on this, it really goes back to what Dr. Catron was speaking about earlier. If you've been giving a diagnosis that is terminal, just speak to your physicians about it. Any physician you speak to should be able to guide you in the direction. So, yes, did you want to speak to that?
Yeah, if you do want to know, or if you're asking about a referral, under the Medicare benefit, you don't necessarily have to have a physician who is referring you. You can self-refer, and you have that ability. You personally can call a hospice agency of choice and say, we're interested in learning about hospice, I think it might be time. And the hospice can come in and do an in-home evaluation and make a determination as to whether or not you would qualify for your benefit. And again, where we don't have a providing physician available, your medical director, the hospice medical director, can provide the initial certifications that are required to enact that benefit. And one other thing, a big question that we do get is, what does hospice cover? As a Medicare and an insurance benefit, hospice will cover all the care that is required for managing your end-of-life illness. So, for example, if your admitting diagnosis to hospice is COPD, we would be responsible for providing the care and coverage for anything related to managing your COPD. So that could include medications that treat your COPD, that could include machines, if we do continue those, that could include social resources that are needed, other medical equipment in the home. If you're so short of breath you can't walk 10 feet to the restroom, we provide the equipment that's needed to help ensure that you're able to function within the home. What hospice does not cover is management of disease processes that are not related to the life-limiting diagnosis. So if you're on hospice for COPD and you have a concurring diagnosis or a comorbid diagnosis of diastolic heart failure, we will not cover medications that are used to manage your heart failure. Those would still have to be paid for through your private or through your Medicare insurance, okay? And in the hospice agency, the law requires that we identify which medicines go to which diagnosis so that the insurer will understand what we are responsible for and what remains the responsibility of your Medicare or private insurance program. That's all that paperwork I was telling you about in the background. It's no fun. I wish we could just do it all, but unfortunately we do have these rules we have to live by. One other thing I'd like to just say, we three are representatives of your local homegrown hospice, Blount Memorial Hospital. But I want to let you know, all hospice agencies fall under the same regulatory guidance. There are other hospice agencies out there, so bear in mind when we talk about how we provide services and benefits to our patients, really that is the expectation and requirement of all hospice agencies that are out there.